Okay, now back to Chapter 28. Care of the patient requiring oxygen therapy. Interprofessional collaborative care, oxygen therapy. When we're assessing and we see shortness of breath, nasal flaring, use of accessory muscles to breathe, pursed lip or diaphragmatic breathing, people who have decreased endurance, or their skin or mucous membranes are changing in color, perhaps they're pale or cyanotic, these can all be indications that oxygen therapy are needed. What is the purpose of oxygen therapy? Well, it relieves hypoxemia. Hypoxemia is low levels of oxygen in the blood. Hypoxia is decreased oxygen levels in the tissue. The goal is to use the lowest fraction of inspired oxygen for acceptable blood levels without causing harmful side effects. ABG analysis is the best measure to determine the need for oxygen therapy and to evaluate its effects. But ABG therapy takes a while to get back from the laboratory. So therefore, we need a quicker, non-invasive monitoring system to see when a patient may need oxygen. And that is where we use pulse oximetry. It is a quicker, non-invasive monitoring, such as pulse oximetry, to determine the need for oxygen therapy. Again, just like with ECGs last week, we treat the patient, not the number. What are the hazards and complications of oxygen therapy? Combustion. Combustion. Now keep in mind, oxygen does not burn, but it enhances combustion, so fires burn better in its presence. Prevention. You want to make sure that there are no open flames or cigarettes in the presence of oxygen therapy. We need to post a sign that says no smoking or no open flames in a room where oxygen is used. In the case of chronic patients where they are still perhaps smoking, you want to remind them that they have to not only turn off the oxygen, but remove themselves from the room in order to smoke their cigarette. They need to remove themselves from the room and shut the door to that room. Electrical equipment within the rooms that where a patient has oxygen therapy, the plugs need to be grounded. Continuing with the hazards and complications of oxygen therapy. Retention of CO2 is seen in patients with chronic lung disease, but the hypoxia drive theory has been disproven. Research has found that patients with chronic lung disease are at risk for oxygen-induced hypercapnia, but not for severely reduced respiratory effort or hypoventilation. So how do we prevent this? We do administer oxygen to patients who have a history of retaining CO2, but we administer it at the lowest liter flow needed to prevent the hypoxia. Continuing with hazards and complications of oxygen therapy. Oxygen toxicity. Oxygen toxicity is related to the concentration of oxygen delivery, duration of oxygen therapy, and the amount of lung disease present. How do we prevent it? Well, we use the lowest amount of oxygen needed to maintain gas exchange. We notify the provider when the PO2 on the ABGs is 90%. We prevent using high levels of oxygen unless absolutely necessary. And one of the ways that we can decrease the amount of oxygen necessary is by using CPAP or BiPAP. We also, if those are not successful, intubation may be necessary. Continuing with hazards and complications. Absorption atelectasis occurs when high oxygen levels are delivered and the nitrogen from the room air is diluted. Oxygen diffuses from the alveoli into the blood, and the alveoli collapse, causing new onset of crackles and decreasing our breath sounds. How do we prevent that? We use the least amount of oxygen necessary. More oxygen hazards and complications. The drying of the mucous membranes. The way we prevent this is when anytime oxygen flow rate is greater than 4 liters per minute, we use humidity. This is to prevent the damage to tissues and integrity. Another complication is infection. And how do we prevent that? Well, the humidity is helping so we don't break down our mucous membranes, but unfortunately, this humidity can be a source of bacteria. So how do we prevent that? We change the equipment per agency policy, which historically is for the humidity bottles of the humidifiers every 24 hours. And nasal cannulas and masks are exchanged usually about every 7 days or when soiled. Oxygen delivery systems. Oxygen delivery systems. The type used depends on the oxygen concentration required and what is needed to achieve it. The importance of the accuracy and the control of the oxygen concentration. Patient's comfort. Do we need humidity or not? And the patient's mobility. Is the patient mobile? Do we need to be able to go to the store, or is the patient staying in the bed? Let's first look at low flow oxygen delivery systems. These are your nasal cannula between 1 to 6 liters, a face masks, whether they're simple, partial rebreather, and non-rebreather. There's a beautiful table on, we are on page 532, that talks about the comparison of the different low-flow oxygen delivery systems, nursing interventions, and rationales on why they are important. I would know that. That would be on page 532, table 28.1. Nasal cannulas are often used for patients with chronic lung disease because they are easy to use and they are very mobile, and the patient can use them at home easily and take them to the store or wherever they need to go. The nasal cannula, the prongs, that is used between 1 to 6 liters. Now, oxygen concentration is, remember, room air is 21%, so 1 liter is 24%, up to 6 liters, which is 44%, can be achieved. Now, even if you increase that past that 6 liters, you're not going to increase your gas exchange because the anatomical dead space is already full. And so people who say, well, we cranked it up because we needed to get the O2 sats higher, it really doesn't work that way, because once you have the anatomical dead space full, you can't really get any more. You do need to make sure that the patient has patent nostrils, and you want to assess for changes in their respiratory rate and depth of their breathing. Now, a simple face mask delivers oxygen up to 40 to 60%, a minimum of 5 liters per minute. Mask needs to fit securely over the nose and mouth, and you want to monitor closely for risks of aspiration, because a lot of times if the patient vomits and they can't get the mask off quick enough, there can be a risk of aspiration. Now, the next two masks we're going to talk about, people sometimes will get them confused, okay? The partial rebreather provides 60 to 75% with a flow rate between 6 to 11 liters per minute. All right, these masks have a reservoir bag, but no flaps. With each breath, the patient rebreathes about 1/3 of the exhaled tidal volume, which is high in oxygen, and it increases the fraction of inspired oxygen, or the FiO2. For best oxygen delivery, be sure that the bag stays slightly inflated at the end of inspiration. You will see partial rebreathers a lot of times misused in the hospital or incorrectly. You'll either see the exhalation ports being blocked, or the reservoir bag is not inflated. and it's just all smushed together. And at that point, you really have just a simple mask. So you want to make sure that that reservoir bag is slightly inflated, that it's not all smushed together and deflated, and that it doesn't have too much moisture. A lot of times these will get really gunky pretty quickly, and will have to be changed because they'll have visible goo, for lack of a better term, or respiratory secretions on them, and they'll need to be changed out. Lastly, in the low flow oxygen delivery systems, we have the non-rebreather mask. This is the highest level of O2 that can be delivered through the low flow oxygen delivery systems. It can deliver an FiO2 greater than 90%. It's usually used in unstable patients that may end up requiring intubation. We do need to make sure that the valves are patent and functional. The non-rebreather has a one-way valve between the mask and the reservoir, and it usually has two flaps over the exhalation points. These valves allow the patient to draw all needed oxygen from the reservoir bag, and the flaps prevent room air from entering through the exhalation ports, which will dilute the amount of oxygen that the patient is getting. During exhalation, the air does leave through these exhalation ports, while the one-way valve prevents exhalation air from re-entering the reservoir bag. The flow rate is kept between 10 and 15 liters per minute to keep the bag inflated during inhalation. And these patients are really not stable, and they need to be assessed frequently. The book says that the patient doesn't need to be assessed but hourly. A lot of times these patients are needing to be assessed more frequently than that, and probably are going to require a higher level of care more quickly. We'll come back with part 3, and we'll start with the high flow oxygen delivery systems. Yay!